Hello, everybody. Welcome back to the IIH Practitioner Series. Today's lecture is Novel Advanced Imaging and Treatment Paradigms for Patients with IIH and Pulsatile Tinnitus with Dr. Omar Choudhri and moderated by Dr. Pierre Goban. Dr. Goban is an internationally recognized expert in the field of interventional neuroradiology with more than 2 decades of experience in the treatment of vascular diseases of the brain, head, neck, and spine. He's a pioneer in endovascular treatment of cerebral aneurysms and has also developed and established minimally invasive surgical approaches to treat acute strokes. He's a professor of radiology in neurosurgery and neurology at Weill Cornell Medical College, as well as director of interventional neuroradiology at New York Presbyterian. He's an inventor and an author of more than 100 articles and reviews pertaining to interventional neuroradiology, and he is founder and CEO of Serenity Medical, which is actually the sponsor of this webinar. Dr. Omar Choudhri is an assistant professor of neurosurgery and radiology at the University of Pennsylvania. He's a dual-trained cerebrovascular neurosurgeon with fellowships in skull-based surgery and interventional neuroradiology. He co-founded and is part of a multidisciplinary program for pulsatile tinnitus at Penn in close collaboration with colleagues from neurotology, headache, neurology, and neuro-ophthalmology. During his time at Penn for the past 7 years, Dr. Choudhri has developed novel methods in diagnosis, workup, and treatment of idiopathic intracranial hypertension and pulsatile tinnitus. He's excited to share how these tools have become integral to the management of these patients in his practice, and we, of course, are excited to hear from him. So thank you, and I introduce both gentlemen.
Thank you, Barak, and thank you, Pierre and Serenity Medical, for giving me this opportunity to talk about a topic which I am very passionate about, and I'm sure a lot of people on the call are as well. And I think it really provides us this forum for being able to share what we know and what we don't know, and discuss some ideas, and hoping to learn more about this disease and how we do it in our practice. So I'm going to share my slides, and Barak, you can confirm if you're able to see my slides, and we'll jump right in. All right. So just like Barak said, by way of background, I'm a neurosurgeon, and I didn't quite know that, 15 years ago, fast forward, I would be, talking about IIH and I would be talking about pulsatile tinnitus. But it's interesting how your career evolves and how you learn things, and, you realize what you're passionate about. So I'm going to share a little bit about, how I think about idiopathic intracranial hypertension. There's quite a bit of overlap fit with my practice for patients with pulsatile tinnitus. And I think we have, found a couple of novel things in which we image venous system and how it has helped us understand these things. So, a couple of things that, everyone on the call is well aware of, on how this disease can really affect a large segment of the population, predominantly women in the reproductive age, in association with obesity. And often, the diagnosis can be tough or can fall through the cracks, particularly as patients are seen through different practitioners that may not be that familiar with the variation and the spectrum of this disease. And from the neurosurgery perspective, it was really described by Walter Dandy, who's considered one of the fathers of neurosurgery, as intracranial pressure without brain tumor. And that's where that whole term of pseudotumor cerebri came about. And, this disease has taken a lot of names over the years, but the theme remains common, which is increased intracranial pressures in the absence of a mass lesion. And there's a lot of criteria we use. There's the modified Dandy criteria, which are a lot more loose, and the traditional criteria, which talk about signs of papilledema and headaches, and the absence of localizing neurologic signs except sixth nerve palsy that can happen with high intracranial pressures, normal brain imaging, and absence of mass lesions, a raised ICP, and patients should be otherwise awake and alert. And this has been evolved further. One of my colleagues, Dr. Grant Liu, who's on this paper, where they talked about these Friedman guidelines, where they've made a little bit more nuanced and more fine-tuned in terms of how the diagnosis of IIH is made. And these criteria are pretty strict. So if you really follow them to the T, you'll really realize how one can be very thoughtful about diagnosing IIH. So the definitive criteria include, papilledema on neuro-ophthalmologic examination, the patient's having a normal neurologic exam, except for cranial nerve abnormality that we mentioned, neuroimaging findings, uh, demonstrating no evidence of a abnormal lesion and normal CSF composition and opening pressure of more than 25 in adults and more than 28 in children. And they say a properly performed lumbar puncture, which means that the patient is relaxed in a lateral decubitus position, and we really aren't having any overlapping factors. And then for other things such as the probable diagnosis or possible diagnosis, you could have absence of papilledema, but then you have to have an abducens nerve palsy, which is a sixth nerve palsy that indicates, stretch of the nerve from the high pressures. And the probable diagnosis would be if there's no papilledema or sixth nerve palsy, then you got to have some neuroimaging criteria that, been covered in other sessions on this forum before, including empty sella and null talk about those things, including flattening of the posterior globe on the MRI, the distension of perioptic spaces, and the transverse sinus stenosis, which is kind of the area where it all comes together for myself and for the other practitioners. So presentation, headache is very common, often migrainous, pulsatile, painful. Visual disturbances can take the features of floaters, diplopia, visual loss, and otologic symptoms include pulsatile tinnitus that can be present in a large percentage. And again, there's patients that decompress themselves with the high pressure through an opening in the skull base or dehiscence, where they can experience a CSF leak from the nose. And it's interesting that, there's a lot of schools where, this is off, the venous sinus stenting is often considered as one of the ways to stop the leaks with upfront stenting, but more on that, as we discuss this. But those are the most common presentations. And this is probably one of my most, most interesting slides. And the thing that I really enjoy talking about is that the pathophysiology of idiopathic intracranial hypertension is really incompletely understood. It's multifactorial, and it's really a balance between the cerebrospinal fluid production and absorption. But I think the story all comes together with centripetal adiposity, where there is production of androgens, there is production of immune, autoimmune, inflammatory factors that somehow lead to increase in CSF production and decrease CSF absorption, leading to high intracranial pressure. The role of venous outflow obstruction, where we see venous sinus stenosis, is important. And then there's the glial lymphatic dysfunction, which reduces CSF absorption, and the lymphatic outflow obstruction also contributes. But, we're going to talk a little bit more about how the story about the venous outflow obstruction come together. But the adiposity or obesity is something that's a very important and common theme. And this is kind of how it works: metabolic syndrome, cytokines, increased cortisol production, all those factors leading to intracranial pressure, where, easier said than done. One of the very good treatments of idiopathic intracranial hypertension is losing weight. But, as we all know, that given severe symptoms, that's sometimes easier said than done. But it does open the door for understanding the pathophysiology and how we talk about managing the patients that present with this. The imaging features, one of my important things to ask trainees when we train them during their residencies and fellowships, and what are the most common signs. And, empty cella or partially empty cella, which means that there is invaginative CSF into the cella because of the high intracranial pressures. You see it on this MR with that white arrow, and on the sagittal CT as well. And then you have very large CSF spaces around the optic nerve with some tortuosity. You see this on the coronal MRI as well, and you see some tortuosity of the optic nerve over here. And you have very prominent CSF collections kind of right in the area of the Meckel's cave at the skull base. All of these indicating things that the pressure is high in the spinal fluid, and they're really finding spaces to accumulate CSF here. Now, when we talk about treatment options, we've had some excellent talks on this forum from people who are experts in bariatric surgery, from people who treat idiopathic intracranial hypertension medically, with talking about the role of Diamox and Topamax and serial lumbar punctures, and role of VP shunting and optic nerve fenestration. And we're really gonna, take the the role of talking more about venous sinus stenting. Now, how does venous sinus disease and idiopathic intracranial hypertension all come together is fascinating, and there's a lot of hypotheses, and every one of those hypotheses seems a wonderful story until it's nullified by a different hypothesis. So, venous sinus stenosis, I think one thing to understand is it's very common in IIH. It's seen in more than 90% of patients, and I think it's important to know that we really have to understand, what does venous sinus stenosis mean? What does it look like? Is it a morphology problem? Is it a physiology problem, or both? And there is some controversy in terms of how mechanisms of venous narrowing contribute to IIH. And I do want to introduce the concept of extrinsic versus intrinsic stenosis, and how we use imaging and workup of the venous disease and idiopathic intracranial hypertension. So the most common pathway is that, if there's a primary care physician or neurologist or a headache specialist suspects a idiopathic intracranial hypertension, and they realize that one of the criteria in the Friedman imaging criteria is to look at venous sinus stenosis and other findings, they order an MRV. And often we see these findings, you can see with the blue arrows, where there's narrowing or attenuation of the venous sinuses on the coronal and sagittal view. And on a CTV, you get even, a better resolution. But it's interesting is that more often than not, the MRVs are called as normal. And there was an interesting study in AJR where they actually looked at the studies of MRV and compared them to higher resolution studies like CTV or venography. And they noted that, in radiology, more often than not, radiologists would tend to call the venous sinus narrowing as more of within variation of normal venous anatomy. And I think that's on some level is true, because there's a lot of patients that we see venous morphologic changes that may not have symptoms. But when you see it, it's pretty pathognomonic in patients with idiopathic intracranial hypertension. After these initial non-invasive imaging studies are done, we take a step forward and look at venography. But this is a good paper from AJNR that basically says that if you look at MRVs, you're going to be able to pick up the stenosis in 94% of patients. And even if you don't have an MRV, and if you have a post-contrast thin cut volumetric images on the MRI, you can still pick it up in 83% of the cases. And that often happens when I see patients in my office with tinnitus, pulsatile tinnitus, or IIH, and they haven't had an MRV. Often looking at a thin cut MRI, SPGR sequences, you can really tell that there is some narrowing in the venous sinuses as a shortcut and really picking up these cases. So venous sinus stenosis is in some ways a very sensitive marker of patients with idiopathic intracranial hypertension. So how do I work these patients up? Often we do an angiogram, and we often look at the venous phase. So this is the venous phase, and you can see, compared to the other sinus, you really lose the venous sinus in that segment where it gets really stenosed. And that's something that, I really want to bring the attention to all the audience, is that this is a real narrowing. So you see the sigmoid sinus going down right here in the transverse sigmoid junction. You see the vein of Labbé, which is the dominant vein of the temporal lobe, inserting here, and you can see how there is a change in caliber. Now, the same patient had an MRV that was read as normal, and you can see, looking at the other side, how the venous sinus is a lot more patent, a lot more open. So being able to see this and comment on this and identify it, this should be able to be done by any neurointerventionalist who's doing an angiogram, by really focusing on the venous phases. I think the interesting thing is that when we train trainees for doing angiography, angiography often turns into arteriography, where we really focus on the arterial phase, and the venous phase really ends up being, things that often we don't focus on, because at that time, if we're doing an awake angiogram, the patients may have a little bit of movement, and the image quality would be a function of the amount of contrast given and the flows and everything. But really picking up these sinus narrowings and 2D imaging is the first step. Now, we do, and a lot of other centers do, something called venous phase 3D imaging. And that basically is the same angiogram that we're doing, where we're injecting contrast into the carotid artery or vertebral artery. But rather than doing 3D imaging in the arterial phase, we introduce something called an X-ray delay. And that X-ray delay depends on the arteriovenous transit time in that patient. And that can be assessed by looking at the last image that we looked at, which is by counting the number of seconds it takes for the contrast to go from the artery to the vein side. And that's the amount of delay that we put in order to get this venous imaging. Again, a great method which does not involve any significant changes in protocol, but really allows us to give a 3D volumetric view of what a venous sinus narrowing looks like. But again, involves patient cooperation. You got to understand the transit delay time and, have good quality flat panel imaging to see that thing. Now, another thing that we've started doing is that whenever we do venous sinus pressure measurements, which we will talk about a little bit, we often put a catheter into the superior sagittal sinus and we do a 3D injection from that perspective. So this is an example of what that looks like. So we have a catheter that's placed into the superior sagittal sinus and we're injecting. And the beauty of this is that the contrast is flowing down in an anatomical fashion down each of the transverse sigmoid sinuses, and we really can appreciate the narrowing in these sinuses in a very nice fashion. And the quality is certainly higher than what you get in the venous phase imaging because you're directly injecting into the veins. And the challenge is that in arteries, when you inject, you're injecting in direction of the arterial flow. So you're going to follow the normal flow of blood going from arteries into the brain parenchyma into the veins. But when you try to inject the jugular veins, you're injecting against the flow. So this is a way to overcome it where you go all the way across the sagittal sinus and you follow the normal physiologic flow by injecting there and seeing how the sinuses fill. And you can do that thing in a 3D phase as well. And this is a very nice demonstration of a 3D venous phase venogram with injections through the superior sagittal sinus, where you can appreciate narrowing of both the transverse sigmoid sinuses in a patient with severe symptomatic idiopathic intracranial hypertension. And you can see that because of the backflow and the high pressure in the superior sagittal sinus, you're filling this emissary vein that goes and fills backwards and joins the skull base venous plexus for the condylar veins and stuff. But again, these kind of images are often very difficult to appreciate when we do venous phase imaging, but really opens a new window for understanding on how we look at veins and how we understand venous anatomy. We basically, do that for all our patients with IIH and helping to understand that. Now, another technique that I use and we've come up with and would love to hear everyone's thoughts on is to figuring out a process where you can study the veins by injecting them against the flow. And the way we do that is we use a technique called a retrograde balloon assisted phlebography for studying those veins. And these are some papers that kind of show what the average size of jugular veins is. It's around 11 to 13 millimeter at the skull base. And there's some work on the suprasagittal sinus. This is one of the papers from Pierre actually that talks about the suprasagittal sinus and transverse sigmoid sinus average sizes, and you can see they kind of range between 7 to 9 millimeters usually, which is important when we consider about balloon occlusion or stenting for these structures. So the way this technique works is that we go into the jugular vein and we introduce a balloon guide catheter. And we use that balloon guide catheter to inflate and occlude the jugular vein temporarily or the sigmoid sinus temporarily. And we inject to overcome the venous flow to study the skull base sinuses better. And the beauty is that, it allows us to get the real sizing of the sinuses when we're sizing stents. And that's a whole other area of discussion in terms of how we size our stents. It's been safe in our studies and has optimal 2D and 3D resolution. I'll show you. And, often people say that it's a non-physiologic injection. You're trying to inject contrast against the flow. And how does that help? And, we'll show some images to convince people otherwise and share some experience in terms of how we've done that. So this is kind of how it works. So we use a very compliant balloon. So when we're trying to inflate the balloon into the sigmoid sinus, we use a balloon that goes up to around 8 or 9 millimeters. And then when we try to go into the jugular vein, we use a balloon that goes up to 13 millimeters. And we inject to overcome flow. This is a patient who had a sigmoid diverticulum on the left side with pulsatile tinnitus, and we placed a stent that you can see, and these are the coils placed into the diverticulum. And from that injection in the sigmoid sinus with this balloon inflated, we're able to fill the whole venous system at the skull base in a very nice fashion. And This kind of, high resolution imaging of the skull base sinus really shows redundant venous channels. It's interesting if you do an angiogram or a venogram with someone laying supine versus sitting up versus standing, you're going to see filling of different veins because when we're laying down, you preferentially tend to drain through the jugular venous system. When we're standing up, it's more through the paraspinal system. But using this technique really helps you see the whole venous anatomy at a very high resolution level. So in this pictures, we actually have used a 14-second high resolution injection for this venography. And you can see how nicely it demonstrates the infrapetrosal sinus, the sigmoid sinus, the transverse sinus, the skull-based condylar venous plexus. And you can see this in this picture, kind of illustrating it in the same way. And it really reminds me of these cadaveric corrosion casts, these papers from Philippe Gayud and Sanmel Ruiz, where they've studied this venous anatomy by injecting NBCA glue and, methyl methacrylate and kind of seeing all these venous channels. And the beauty of this is that it just tells me that how we're just scraping the surface. There's so much detail and so much stuff that we don't know about venous anatomy. And this is just another tool that helps us understand things that we don't know about venous system. And again, how it ties in with IIH. So this is kind of a retrograde balloon-assisted venography with inflation of the balloon in the sigmoid sinus with a 3D run that shows us all these veins and anatomy and helps us give us additional information. And this is a patient who has severe venous sinus stenosis that we've done the same technique on. The balloon is inflated in the jugular vein, and you can see in a really nice detail the extent of disease, the irregularity, and the narrowing of the venous sinus that often we're not able to appreciate or are not able to talk about before making treatment decisions for a lot of patients. So it's just another tool for helping us understand venous anatomy in patients with IIH and pulsatile tinnitus. Now, how exactly it's done? I do all my work through the right upper extremity. So we do a right-sided radial artery axis for arteriography, and we go through the basilic or cephalic vein in the arm for the venous work. And we are able to navigate our balloon through an 8 French or 9 French system through these veins into the jugular vein, inflate it, and do these venous injection. And allows us to get those nice images and to measure pressures and to know everything and anything about the venous system. In these patients, there's a lot of different vendors that make these balloons. The biggest one is this balloon from EO Solutions called Dr. Balliner Balloon Guide that goes up to 13 millimeter and that comes in useful for jugular occlusions. And then there's others from other companies that help too. Again, the thought being that venous occlusion with the retrograde injection can give you better imaging. And this is another example of how an injection over here can really help us see things like fenestrations, things like flaps, things like diverticula, and all those things, and also skull base anatomy. But one thing to understand is that the reason for having all this is not to say that we're rubbishing or saying that the venous phase imaging is not good. The venous phase imaging from an arteriogram is still great for showing cortical veins, on how they insert and all those things, but taking it together with the venous injection or venogram, it just opens a whole other layer of information. So this is an example of another patient with venous sinus stenosis with a retrograde venogram, some benchtop experiments that we did in our patients, around 36 patients that we've studied. But this slide kind of shows the comparison. So let's suppose we have a patient with that we're undergoing a study for, and we did an MRV. This is the level of detail and quality you would get on an MRV. And this is great for kind of showing patients in terms of what's the meaning of doing advanced imaging. And then we do an angiogram with the venous phase imaging, and you get this degree of detail. Again, very nice cortical vein detail, parenchymal phase, kind of see how the vein's looking like. And then we try to inject the vein without a balloon. And this is kind of what happens. You try to inject the jugular vein, and the flow is so much you can't overcome it, and you don't see anything. But then with the balloon inflated, you can see all this anatomy and detail, which was not possible until you get that occlusion and you can overcome the flow. But, I just found it useful to talk about this because it just gives another perspective in studying these patients. Fusion 3D imaging is another useful tool that I found in studying venous disease in IIH. And what does that involve? That involves us, for example, in this particular case, we have fused the venous phase imaging with the superior sagittal sinus injection. And what it helps us appreciate is that in pink, you have a superior sagittal sinus injection, and in blue, you have a venous phase imaging. And you can see that both these are complementary. The venous phase imaging really helps us with like the pterygoid plexus here, with the cortical veins and some venous sinuses. And sagittal injection really gives us that extra oomph that you need for looking at the transverse sigmoid sinus, and bringing them together really helps you study the whole venous anatomy and system. Same thing goes when this is someone that I took care of last week, that also we fused the two, and you can really start to understand emissary venous system, the skull-based venous systems, by fusing the two sets of images. The next is the concept of talking about bony anatomy. I think when we study IIH, when we study idiopathic intracranial hypertension, it's very important to understand what's happening to the bones as a result of increased CSF pressure. Is it resulting in bony erosion? Are we having dehiscence? Are we having areas where there's diverticula? And I think doing very high resolution bony imaging on flat panel imaging systems really helps us see areas where the bone is fissing, where the inner ear is, and what's the association of the venous sinuses and the emissary veins, and helping understand that. And that's another tool where I found diagnosing people with things like Eagle syndrome, diagnosing people with Bowhunter syndrome, diagnosing whether or not an emissary vein could really be an answer, is sometimes helpful, and gives us really good answers in certain cases. Um, the other thing that I found useful is that, as part of the workup for pulsatile tinnitus in particular, often in association with IIH, is to look for bony dehiscence, is to see whether or not there's an area where there's bone missing or the bone is eroded. And we often do a temporal bone CT as an outpatient. But we found that using flat panel imaging and with using high resolution 14-second Dyna CTs, or a cone beam CT, we can get resolution better than a temporal bone CT, which obviates the need for doing this extra set of imaging and gets almost a one-stop shop for looking at all these factors. So uh, it's high resolution, looks for emissary bone channels and high riding jugular bulb. And this is kind of what the quality looks like. If you look at this quality here, you can see to what degree it's nicely able to show all the anatomy, the foramina and everything, which is better than any CAT scan and any temporal bone CT. So routinely, if we know the site of pulsatile tinnitus, we're able to really go down and look at what the thickness of bone looks like around the diverticulum or the sinus, whether there's a bone missing, what the inner ear looks like, what the cochlea looks like, and really make some very good decisions in terms of the anatomy. And it just adds a few extra minutes when we study these patients. This is another example of a patient who had a venous stent, and you can see it helps us understand stent apposition. It helps us understand how far a stent goes, gives us lessons about sizing of the stent, and it really provides excellent imaging and quality while studying these patients. So I really feel like, this extra step of imaging just opens new doors in terms of us helping to understand the whole pathology here. Now, venous stenting and evidence, I'm sure there's people on this call who know this topic better than I do, but I wanted to share some perspectives. This was one of the very early papers from early 1990s from Stanford with Bart Lane and Michael Marks, kind of the same center where I did my fellowship. They published the first paper for venous stenting. And I'm surprised because at that time, I'm sure that paper got buried amongst other articles. And it's interesting, like so many years later, venous sinus stenting has really taken center stage. But we have better tools and things coming underway we shouldn't forget the history and how this all started. Um, I think, talking about venous manometry, and I think the more that I treat cases, I realize how important venous manometry is. And the first paper for that was published back in 2003, 1995, where there were 9 patients treated. And then in early 2000s, there were bigger series in terms of really studying that the pressures inside the venous sinuses mean something. And, again, studying things such as, the anatomy in the venous system and how the pressures correlate. And I think we cannot overemphasize how important that is before we make treatment decisions for idiopathic intracranial hypertension. Now, this is I think if there's nothing that the audience takes away from this talk, I would love for them to quite understand, and I'd love to hear Pierre's thoughts at the end of the talk as well, as the difference between the intrinsic versus extrinsic venous sinus stenoses. And I think that's interesting because when we think about venous sinus narrowing and how it contributes to IIH, there's two schools of thought and there's two groups of patients that we look at. One is intrinsic stenosis. So you have a prominent arachnoid granulation or a web or a fenestrated or a blood clot causing focal acute narrowing. In some cases, there may be tumors or meningiomas growing into the sinuses, causing abrupt narrowing that are a trigger for venous hypertension. And what it's causing is that it's impeding the absorption of spinal fluid, causing venous backup, causing high venous pressures, and causing, in turn, a high ICP. And these patients respond great to focal stenting because apparently, based on this hypothesis that I've put forward, you're treating the cause of the idiopathic intracranial hypertension. On the other hand, there's people in which it's not the venous narrowing that triggers the IIH cycle, but it could be secondary phenomenon like, the glymphatic cycles or the weight gain and other things that lead to ICP elevation. But because of that ICP elevation, it leads to pressure on the transverse sigmoid junction, causing them to become secondarily narrowed. So a lot of people would argue we really shouldn't be treating patients with IIH with extrinsic venous stenosis because it's not the cause, but the result. But the argument against that is that if you treat the narrowing leads to a cycle that leads to increased CSF and increased pressure, and you have to break that cycle to actually get a response to stenting. And this is kind of how I demonstrate that with the advanced venous imaging. This is the venous stenosis, prominent arachnoid granulation seen on this venous 3D imaging. And the extrinsic narrowing is kind of long segment, it's narrowed, it's tapered, and it's clearly different than this focal disease that we see that appears to be more intrinsic. And how does this all come together? Kind of repeating myself here with this flow chart. The intrinsic stenosis leads to venous outflow obstruction, that leads to venous hypertension, that leads to elevated CSF pressure, that leads to patients having IIH that's treated by stenting, by treating the cause. And in the extrinsic cycle, it basically venous obstruction and the CSF pressure can be broken down by treating this with stenting and preventing this, positive feedback cycle. Now, there's been papers that argue for both. So there's a paper coming out of UVA where they have transient resolution of venous sinus stenosis after high volume lumbar puncture, and that argues in favor of the extrinsic mechanism, which means that as soon as you drain spinal fluid, they saw that the sinus, which looked narrowed, suddenly looked normal, and it's because it was not the primary cause, and you're taking the pressure away, and that makes sense. And again, these are concepts, again, that, Pierre has talked very eloquently about in the past, where, you have a lot of things happening in IIH. You have headaches, you can have pulsatile tinnitus. Some people are getting decompressed through a spontaneous leak and headaches and opening pressures. And you really have to have a multidisciplinary team, people who understand how these all come together. It's not one size fits all. Patients may present in different ways in IIH. And just reiterating the point about venous morphology and physiology, venous narrowing is not always associated with impaired flow. It needs to be qualified by a pressure gradient, and that's why we do venous sinus manometry. Important to do it awake and not under general anesthesia, because we know that there can be changes and decrease in that gradient or loss of the gradient under GA. And a pressure gradient of 8 or higher is what we use for stenting. In select cases, you can go to 4 to 7, but you're going to lose benefit in those cases. So in my practice, if patients have pure IIH that's qualified by a modified Dandy and Friedman criteria, you really stick to the 8 millimeters. But if it's pulsatile tinnitus, that's a dominant symptoms, then we're a little bit more loose and okay to offering venous sinus stenting to patients if it's bothersome, debilitating pulsatile tinnitus, even though they may not qualify for the entire spectrum of IIH symptoms. So venous sinus stenting for IIH works in my experience, and for a lot of the other experts and people on the call. There's 3 meta-analyses that have been published that talk about improvement of papilledema in more than 90% of the cases, headache improvement in 80%, pulsatile tinnitus improvement in 90% of the cases, and 2% complication rate. and venous sinus stenting lowers intracranial pressure. So this is an argument more in favor of the intrinsic disease. And this is a paper from Athos who's talked really about separating these cases, and you see a lot more prominent decrease in intrinsic stenosis cases and a faster wean off from Diamox for those people. And again, there have been studies done with intracranial pressure bolts with venous sinus stenting with a decrease that we see over time. Again, these meta-analyses demonstrate decrease in opening pressure in these patients, in patients who undergo retinal layer OCT with decreased thickness of the edema, and decrease in papilledema, improvement in headache, visual symptoms, and the results are very encouraging. And these are the two meta-analyses that I talked about. Now, we often should, recognize the complications. A very common side effect of venous stenting, as we all are aware, is a short-lived ipsilateral headache mainly from dural pressure from putting these stents in. That usually gets better, I would say, in 90% of the patients that I treat within a week or two after the procedure. Often we use steroids or pain medications that help. But again, there's a lot of other smaller rates of complications that talk about sense adjacent stenosis, and we've started doing long segment stenting to normalize the pressure. We've talked about access issues, and that's why I've always done this from the right upper extremity, so we don't have to worry about groin hematomas and stuff. And patients love it, and it works out really well. The stent restenosis rate in my practice has probably been, I would say, in less than 10% of cases, and patients overall do very well. How I do it, again, it's a multidisciplinary team with neurologists, ophthalmologists, ENT, clinical assessment. And then if the stenosis is seen on the MRV or there's a high suspicion, we offer them a cerebral angiogram, a venogram with all the imaging mentioned, the venous sinus pressure measurements, all under local anesthesia and monitored anesthesia care, all done from the right upper extremity. We do a lumbar puncture afterwards for opening pressure in a lateral decubitus position under fluoro. The medication trial for 6 weeks, and stenting is done in a separate session under GA if the gradient is more or greater than equal to 8 noted in an IIH patient. And I usually do 3 months of aspirin Plavix dual therapy and a CT venogram before transitioning to monotherapy. Case example is a 58-year-old gentleman with complete features of IIH. We are doing venous pressure measurements here. And after doing that on the imaging, we were able to note a high-grade stenosis, pretty classic case seen in this patient right here. We gave Diamox a good trial for actually a good 6 months, and then he decided to travel back and get treatment. This is kind of the stent being deployed. We have our guide sitting in the sigmoid, and this is the stent. I think it was a precise stent that we used in this case that successfully was deployed in terms of helping the symptoms. And then if you look at the imaging afterwards, the stenting has been completed. At least from the imaging wise, it's very gratifying, and seeing the significantly improved lumen of the venous sinuses from this. However, on the other end, we have to understand that it's a heterogeneous group of patients. So this is a 40-year-old patient with IIH, and you can see a prominent arachnoid granulation. And when I measured the pressures, there was no pressure gradient, maybe 1 or 2 points. And I decided not to stent this patient, but because it was lumbar puncture diagnosed idiopathic intracranial hypertension, we ended up doing a ventricular peritoneal shunt. So went to stent in diagnosed IIH and venous sinus stenosis patient, the pressure gradient equal to or more than 8. And the patient is either refractory to medical therapy or cannot tolerate medical therapy. Patients with pulmonary papilledema and tractable headaches. And as we know, there's good evidence that it works. And in the right patients with these strict criteria, it can be a game changer. So coming towards the end of my talk, what I would say is that venous sinus stenting is a very viable option for medically refractory idiopathic intracranial hypertension. But like in any procedure, we should not take it trivially. And there's a method to the madness. There's a right way to do this. And it requires a formal diagnosis with a multidisciplinary team. All the patients are seen by a neuro-ophthalmologist. There's documentation of papilledema and imaging is done in the same graduated hierarchical fashion. We do advanced venous imaging. A venous manometry is essential, and we really tailor therapy to patients, and weight loss and medical therapy takes precedence. But in the people who qualify, it works very well. There's a paper that just got published literally, I would say, 2 weeks ago or a week ago, which talks about the national trends in the treatment of idiopathic intracranial hypertension. And it shows that there's an incidence and tendency to use endovascular stenting for IIH that is found to be significantly increased between 2015 and 2018. So the green line that you can see shows the trend in the increase of endovascular therapy. And along with that, you can see a decrease overall in the use of ventricular peritoneal shunting. And the reason is obvious, is because there's issues with the VP shunting where there's a concern for shunt revisions, a significant amount of hardware that's left inside the body, risk of infection, and all those things. But you can see that venous sinus stenting and understanding and awareness of how venous stenosis comes in together with idiopathic intracranial hypertension is still, we're scratching the surface, because it's only being offered to 5% of patients with idiopathic intracranial hypertension nationally, even though venous sinus stenosis is seen in 90% of patients with IIH. So getting a right workup, doing venous sinus pressure measurements, understanding the pathways is important. And I do see that as the understanding, the awareness, the availability of better stents, and understanding of the disease pathophysiology on all fronts, kind of getting to know this disease better will certainly lead to an increase in the venous sinus stenting for the right patients over time. And again, venous stenting offers a lower readmission rate and a shorter hospital stay and duration based on this national and patient sample study. Future directions, we know about the stents that are coming up and the trials that are coming up. And I'm hoping that with this better quality level 1 data or higher quality of data, we're going to be in a much better place in terms of making the right decisions for our patients. This brings me to the end of my talk. Again, thanks to Pierre and to Barack and the rest of the Serenity Medical team for really providing us with a platform to talk about this, to share this on a first level basis with our patients, with the support groups, and to really learn more about the disease in a relaxed fashion, and reaching experts from around the region. So happy to take any questions, and passing it over to you, Pierre.
Sure. Thank you, Omar. That was an outstanding presentation. Yes, there are several questions from the audience. I will start with a simple one. I mean, the answer is not simple, but the question is simple, is what is the long-term outcome of venous sinus stenting?
That's a great question. Venous sinus stenting, long-term outcomes, as far as we understand. I mean, in my practice, I have been doing it for probably around 7 years or so. How many of those patients? I've probably done around 150 patients. I've seen probably 2 patients have recurrence of symptoms. We haven't really had any complications, knock on wood, from the procedure. So in my book, in my shop, I think it's an excellent therapy for the right patients. And if you look at, what the meta-analysis data is and everything, is that slide that I pulled up that kind of summarizes everything, which basically says that, recurrence rate is around 10%, low complication rate, and for different symptoms, it has anywhere from 70 to 90% improvement rate for all those things. But I think the proof is in the pudding. You got to do the right workup and diagnosis. And if you have true IIH patients with true stenosis, with true gradient, you're going to have very good outcomes.
So another question, and the answer is yes, but the question is, can IIH be active in the absence of papilledema?
That's a wonderful question, and I love these questions because they are really emphasizing what I had talked about at the start of the talk, that yes, you can have lack of papilledema and still have IIH if you have other features like imaging features. You have a sixth nerve palsy. Honestly, I don't see sixth nerve palsy that often, even though it's in the criteria. But I
No,
think it's
really rare.
yeah, but more the MRI findings. Yes, you can have IIH.
We have another patient that tells about very interesting history. A patient was symptom of IIH starting at, she was 16-year-old. She was placed on medical treatment. She had several lumbar puncture. Then she went into remission. Then symptoms recurred when she was 30-year-old and then went in remission again. However, now she is left with pulsatile tinnitus. The patient doesn't tell me about the intensity, so I don't know if it's worth treating it or if we can leave it alone. I would say something about pulsatile tinnitus is that in itself, pulsatile tinnitus will not kill you. It can be bothering, it can be terrible, but it is not symptoms that you should be alarmed. You know, it's not because you have even severe pulsatile tinnitus that it's something bad is going to happen. Just so, but this story of pulsatile tinnitus that persists even after all other signs of IH are in remission. What could you tell us about it?
Yeah, I think I completely agree with you, Pierre. I think, I think that's an interesting story. I think, often IIH is a moving target, as we know that, there's metabolic reasons that contribute towards it. There's inflammatory factors that are causing, somehow venous increased CSF production or causing sinus narrowing. And someone comes in, we see venous sinus stenosis, we stent the sinus, the patients feel better. But often, as we know, the venous sinus stenosis may not be the inciting factor. So those other things are going on at the same time. And there have been scenarios where venous sinus stenting has helped, but often patients need to have shunted or need medical therapy at the same time. And often you have to have a multi-pronged approach. But if it's just pulsatile tinnitus, I usually am pretty conservative. I would say less than 20% of the patients that come to me in my office with pulsatile tinnitus, do I even offer a cerebral angiogram? Because my first question is this bothersome or is this functionally impairing? And for a lot of patients, it would be like, I just want to make sure it's nothing life-threatening that's a symptom of it. And if that you tell me that based on non-invasive imaging, I'm fine with stopping here and not going further with invasive imaging. And I think that's where I agree with you 100%. We've got to be thoughtful and treat each patient individually.
So I have a difficult question. IH in children. One of our auditor reports the case of a non-obese 7-year-old boy. And note that it's a boy because in children, IH does not have a sex predominance, but 7-year-old boy, not obese, who has IIH. And I'm not sure how the IH was diagnosed, but the boy, I'm reading, the boy has experienced 2 times extended drainage, and based on ophthalmologist, the grade, so I suppose it's the Friesen grade, dropped from level 3 to level 1 in a couple of days, then goes up to the same level when drainage stops. So I suppose that the auditor wants some advice. We are not allowed to give advice, but let's say some more information about IH in children and how you would manage a case like that if it were referred to you.
Yeah, that's a great question. I think that, in children, even though my practice is mainly adult, I think in children, I like to be a little bit more thoughtful before, making a statement regarding widespread stenting in pediatric IIH. And I think the answer lies in imaging. I think we really need to understand what are the trigger factors here, if it's really true venous sinus stenosis. And I think doing a workup is reasonable in terms of venous pressures and stuff like that. But I do think that, when we talk about putting a venous stent, we're talking about doing antiplatelets, and it comes with compliance issues and the failures and stuff like that. And what I would say is pretty much to echo what you said, Pierre, which is we've got to do a full imaging and a workup. And if it turns out that it qualifies for all those other factors, I think it's a reasonable solution.
So would you place a shunt rather than a stent in children that need some kind of CSF, I mean, that needs a surgical treatment?
Yeah, I think if they qualify for all the factors for venous stent in terms of a large gradient, and I would say, they're in their teens or something like that, and we have good assurance for compliance, I still feel like if someone qualifies, I would prefer a venous stent over a shunt any day.
Okay, okay. So let's go back to adults. Interesting question of same patient who had some remission of IH, but she stated that she has extreme fatigue and some vertigo when she looks up. So is her IH in a remission? Have you seen? I have never seen isolated chronic fatigue in an IH patient, but maybe as a residual symptoms. What do you think about it?
Yeah, I think that's a tough one. I think it really falls in that, gray zone area where, I do see a lot of patients with symptoms that don't quite fit exactly. It just doesn't fit in that box of IIH, and you have fatigue and you have brain fog and all those things. And to me, I like to think of IIH in a much more objective and granular fashion where you have to qualify with, high opening pressure, MRI findings, and all that stuff. And if it's just those isolated symptoms and prior history of IIH, but there's high opening pressures are normal and the imaging findings look pretty much okay. To me, I don't find that as a good starting point for intervening or to have good outcomes with stenting further.
Now, I think that if you have symptoms that are a little bit unusual, I think a lumbar puncture is with measure of pressure is indicated because if you find a high opening pressure on the lumbar puncture, it could be, that the IH is still active.
Absolutely. Yep. That's the objective evidence for sure.
Another question, what do you think of optic nerve sheath fenestration?
Um, that's a really good question. So it's the funny thing is that, when I was in training, I did my residency at Stanford and I've been at Penn here. It's one of those things that I had only read in books, and I had never had a patient that underwent an optic nerve sheath fenestration until I ran into a colleague from Rutgers at the skull base meeting 2 weeks ago, where I was talking about the same topic, and he showed some slides and showed a video on how optic nerve sheath fenestration is done. And I think the fact is that the number of centers and number of people who are actually comfortable doing it is very finite. And I think it works great where you have sudden visual symptoms that are really severe and you can decompress and you really see a lot of CSF coming out and results are good. But I think apart from the fulminant visual worsening and stuff like that, and people being super comfortable with it, I see it being done less and less. I think it's a good treatment modality, but I think it's a very niche group of patients where it applies to.
Yeah, and I have also um, another argument is that so few people, so few neuro-ophthalmologists feel competent to do it. It's that there is a reason, it's that it's very difficult to do safely.
Yeah,
And there are very few people who do it. So there is a reason for that.
agreed.
Another question. So I'm reading the question. Does empty cellar means there is a CSF leak?
That's a very good question, and I think answer is no. The empty cella is basically a demonstration of increased CSF collecting, and there's actually a really interesting paper that I read that actually says, does an empty cella indicate IIH, or does empty cella indicate venous stenosis? And actually that study showed that empty cella more correlates with venous stenosis than with true high opening pressures.
Hmm.
And and that actually tells you that empty cella doesn't always mean that you have a high opening pressure, but kind of indicates kind of the flow dynamics. But to answer the this question, no, it doesn't always indicate CSF leak. But if someone has an empty cella with an IIH with a skull base dehiscence, yes, they would go in line, but the kind of separate.
Yeah, the paper that you are referring to, I think it's the paper from Emmanuel Houdard from
Yeah.
Lavoisier, France. He's a good friend of mine. Yeah, it's we're at the border of what is the significance of venous sinus stenosis and what's the relationship with IIH. And some patients will present with pure tinnitus due to venous sinus stenosis. And, but this patient has never had any sign of IIH. However, when you do the MR, you will see an empty cellar, or you will see other signs that can suggest that, this patient may have had subclinical IH and at one point in their life. So there is a continuum there.
Yeah, I mean, I agree with you, Pierre. I think, as much as we like to say yes, IIH and no IIH, I really think it's a spectrum. And there's some people who may not qualify with those strict criteria, but they have a lot of the things that are suggesting that. And I think it's important to kind of keep that in mind.
So I have another comment, and it is not a question. I'm just reading because it's surprising, but um, so the patient say, my IH started immediately after my first time on a plane, on an air trip on a plane. I had this episode. I was crying in severe pain, thought my brain was going to explode, started with tinnitus, pain in ears, brain on fire, neck pressure. And then, I think it's really rare to have such a sudden start of IH. And I've never seen that. Do you have any experience with that?
Not necessarily. I think when we open up that chapter of secondary causes of intracranial hypertension with, use of some medications and use of some drugs and all that stuff, I think that stuff can happen in a fairly short term, but haven't really had any experiences with someone noticing it immediately after a plane ride or something.
Any relation between IH and meningioma?
Yes, that's a great question, and I like answering that to me because that's a pathology demonstrating pathophysiology in real time. I've had a few patients in which I had a couple that had a parasagittal meningioma, which was small, but it was really going into the straight sinus, sorry, the suprasagittal sinus, and that patient had real signs of IIH, and the question became, do I stent that sinus where that meningioma is? Because there's a good number of papers on that. I personally didn't feel comfortable doing that, and I ended up shunting that patient because that meningioma was small, and I didn't end up want to be in a situation where I end up in the sinus while trying to take that small meningioma out or trying to stent. But that's something that can happen in association. Um, to answer this question, can meningioma cause IIH? The answer is no, if you take the true sense of the word. But yes, it can cause secondary intracranial hypertension. And I've had a couple of patients with bilateral transverse sigmoid junction meningiomas too, causing kind of the same phenomena.
Then we have a couple questions about shunt, programmable versus non-programmable, and a specific question about, is there a lumbar shunt that is programmable? So, as a neurosurgeon, please tell us more about that.
This is for lumboperitoneal shunts, Pierre?
So there is a general question about programmable versus non-programmable shunt in IH.
Okay.
And a second, more specific question about, is there a programmable LP shunt?
Great question. So yes, for ventricular peritoneal shunts, there are programmable valves that we put in that allows us to fine tune things. I think one interesting thing to know is that when you shunt patients with idiopathic intracranial hypertension, their ventricles are very small. So I think, and the reason is, and that kind of ties in with pathophysiology too, is where they say that because it's an impaired lymphatic system, they feel like there's more interstitial fluid in patients who have idiopathic intracranial hypertension. So there's more brain and pushes the ventricles, what makes them smaller in a simplistic thought process. And so whenever we do VP shunts in IIH patients, we always try to use navigation so you can hit that ventricle in an accurate fashion. But a little tangential thought, but yes, there's valves that are non-programmable and programmable. I like to use programmable valves because it gives you a little bit of a capacity to modify settings, and they have to be readjusted after MRI, some of them. Lumboperitoneal shunt, as a neurosurgeon, that's my least favorite procedure, and I generally don't try to do that because you don't really have a great place to tether those shunts in. They often are put in the flank, the valve. And as far as I know, they're usually non-programmable from what I remember. But I mean, to demonstrate my disdain for lumboperitoneal shunts, I've probably done less than 5 of them in my career.
Any relation between a diagnosis of fibromyalgia and IIH?
Honestly, I mean, I see the patients with fibromyalgia, and again, diagnosis in some of those patients is very difficult. For IIH, I feel like there's, clear criteria, like we talked about, like opening pressure, lumbar puncture, and MRI findings. I think there may be features of fibromyalgia in patients with IIH, but I don't see a full overlap between the two diseases.
Last question. Actually, it's already 5 o'clock. Have you seen patients who present with IIH non-pulsatile tinnitus? So non-pulsatile tinnitus, that's something completely different. And visual snow syndrome. If so, does stenting improve the symptoms of both?
Non-pulsatile tinnitus appear, like you mentioned, I think it's a totally different set of differential diagnoses. Having said that, can a patient with non-pulsatile tinnitus have IIH? Yes, they can, because not every patient with IIH would have venous sinus stenosis. But what I would say is that it's not the usual presentation, and I would again follow the algorithm of getting imaging, lumbar puncture, eye exam, and if needed, venous imaging.
That's great. So we are going to close this session. That was great, Dr. Choudhri. Thank you. Do you have a last comment to make?
No, I think I really enjoyed this session, and I think it's my pleasure, Pierre, to connect with you and with the rest of the team, and to really, it's exciting time because I love to see patients and families and champions of this disease really stepping forward and trying to share that knowledge with everyone. So thank you, everyone. It's been a pleasure.
Thank you. Barak?
Yeah, thank you both so much, Dr. Chaudhry, for a wonderful presentation, Dr. Goban for excellent moderation and hearing everyone's questions. Just want to share that we don't have the exact date, but in April, we're going to have a second one of our patient chat sessions, and we hope to be joined by someone who has been mapping her own journey through the healthcare system, and being very open and honest about how sometimes that was quite difficult for her. And that's specifically obviously to do with IIH. I also would like to encourage you all to visit Dr. Choudhry's Twitter account, or it's now called X. You could see him right here. And Dr. _OC_. And I'd also encourage you all to please, if you're not already, visit IIH Hub, where you can see past webinars. And if watching an hour of a webinar is long, you can go to our YouTube channel just at IIH-Hub, and we have many of them. And this one will also be excerpted into much shorter video clips. And so we welcome you to join us in all these places, and we hope to see you in April. Thank you very, very much.